Hello and welcome to the Independent Health and Aged Care Pricing Authority Stakeholder Forum, where we're going to introduce our advice on the bundling arrangements for general use items on the prosthesis list. My name's Joanne Fitzgerald. I'm Acting CEO of the Independent Health and Aged Care Pricing Authority, or as IHACPA, as we're known for short, if you were wondering about our new acronym. And I'll start the session by acknowledging the traditional custodians of the many lands on which we're meeting today. For me, that's the Gadigal people of the Eora Nation, and recognising their continuing connection to land, water and culture. I pay my respect to elders today and those who walk in spirit. In today's session, we'll be introducing our advice on the bundling arrangements and providing you with an opportunity to engage with us on our role in providing that advice through a live Q&A. And I will be participating in the Q&A panel along with my colleagues who will join me on screen shortly. So Kees van Gool, who is our Executive Director of Pricing and Analytics, Trent Yeend, who's our Senior Data Scientist, and James Chen, our Director of Aged Care Costing, who'll be moderating our Q&A session. Before we start, can I direct your attention to the Q&A widget in your web browser, which will allow you to post questions to the panel, and you can also upvote other questions that other audience members have put in the Q&A panel that are of interest for you. And please feel free to add questions prior to the commencement of the Q&A as we're going through the presentation. That is quite fine, and we will get to those during the Q&A session. So let's begin. As many of you would be aware, in the first half of 2022, the Australian Government Department of Health and Aged Care requested that IHACPA provide advice on bundling arrangements for general use items. And the purpose of this advice was to support the private sector in establishing alternative arrangements when those items were removed from the prosthesis list on 1 July 2023. IHACPA undertook a public consultation in September and October last year, inviting feedback to enable us to support the formulation of the alternative bundling arrangements advice. We received a total of 20 submissions, and these were all considered in the development of IHACPA's advice. And I'd like to thank those who did make the submission. We do recognise the time and effort it takes to do that, and we do greatly value the input in helping us come together with that advice. In December last year, IHACPA provided that advice to the department, and the department shortly thereafter published that on their website. And I'm sure many of you, if probably not all of you, have read it, which is why you're here today to ask us some questions. The advice we provided, it details the general use item bundles that IHACPA has defined together with the bundled benefits. It includes information on the application of the bundles. It provides a detailed methodology on their development and supporting analysis. And it also includes a summary of the feedback we received through the public consultation and outline how IHACPA considered that in the finalisation of that advice. I'm now going to hand over to Trent to provide a further overview of that advice, as well as to provide a demonstration of a bundling tool that we have developed and intend to release in early February to assist stakeholders with the application of that bundle advice. Thanks, Trent. That's over to you.
Thanks, Joe, and welcome everyone. Hi, let's jump straight into it. So, as Joe mentioned, I'm going to start today's webinar with an overview and a brief introduction of IHACPA's advice on bundling of general use items in the prosthesis list. We're going to follow that up with a demonstration of an IHACPA GUI general use item or GUI bundling tool that we've developed to support the sector in bundling their existing data and understanding the impact of the actual GUI bundles. And then we're going to come back to the panel for a Q&A session. So an overview of the GUI bundling advice that we have provided. The scope of that advice, this is really in the context of the actual request that we received from the Australian Government Department of Health and Aged Care. The scope of the advice specifically relates to billing codes listed under Part D of the August 2022 prostheses list. And in particular, use of these items in admitted services provided to privately insured individuals in private overnight, private day and public hospital facilities. That's the scope of the advice in which we have defined it. However, that's not to say that the advice itself can't be applied more broadly. In particular, potentially there's a potential for the application to a broader set of general use items beyond just those registered under the Part D of the prostheses list. And similarly, maybe potentially applied more broadly than just privately insured admitted patient services to other admitted patient services with other funding sources. So as with everything that IHACPA does, it is defined, the advice is defined empirically, and it is based in particular upon general use item utilisation observed in the 2020-21 financial year HCP prosthesis data collection, which is a national data collection that records prostheses list billing code charge data across Australia for privately insured services, as well as the episodes of care that those services are provided in and the charges, so private insurance charges associated with those episodes. And that provides a profile of the activity of utilisation across the sector and the benefits that we ascribe to these units of activity or these utilisation of general use items are the scheduled benefits defined as the expected March 2023 prostheses list schedule benefits. And the purpose of that is to define benefit levels that would be in place immediately prior to these items transitioning off the prostheses list in July this year. So that is the scope and the way in which these bundles have been defined. Now let's get on to the actual definition of the bundles themselves. The first, the actual definition of this bundling advice is brought about in 4 stages. The first stage is to actually, we've got the general use items or GUIs identified. Now the first stage is to actually classify the general use items. So we define a product classification of those general use items. The second stage is to define conceptually what the notion of a general use item bundle is. Once we've got those general use item bundles defined and identifiable across admitted patient services, we then can classify those GUI bundles. And then the final stage, after we've classified all of those bundles into N classes, we can then price each one of those N classes. So define the bundle benefits for each N class. So that's what we're going to give an overview of today. The first stage being the classification of GUIs. So we took the Part D of the prostheses list, the general use items defined under Part D of the prostheses list obviously already are assigned to the prostheses list product classification of categories, subcategories, groups and subgroups and so forth. So we effectively define a product classification of the general use items that aligns broadly with the existing prostheses list product classification. There are 24 product classes across that we've defined across all of the general use items. And there's a slight hierarchy to that classification of 2 levels, with the broad level being the product branch level that you see here on the right hand side, and then the full granularity of the 24 product classes. So that's where we start the journey of defining general use item bundles. We define a classification of the products. The next stage is to define the general use item bundles themselves to allow them to be identified across admitted patient services. And so the main point here is that the main aspect of the bundling occurs at the admitted episode of care level. So general use items are aggregated to the level of an admitted episode of admitted patient care. And so in this example, you've got 11 general use items that are being used illustratively in a single admitted episode of care. So they're the items of interest that we're looking to bundle. The next stage is to assign or identify each one of these general use items with their product class that they are associated with. And so in this example we've got 11 general use items, but they really come from one of 3 different product classes that we've defined. So that's the second step of the bundle definition. And then the third step is really to associate a bundle with each one of those different product classes. So general use item bundles are defined as a collection of general use items within the same episode and from the same product class. And so in this example, we start with 11 general use items, and they're translated to 3 general use item bundles. And so at that point in time, so we've defined a product classification, we've identified general use items as the scope of items, and then now we have all of the bundles defined across all admitted patient services. There's no change to the bundles. They're not split in half. They're not combined together to create larger bundles. That is the static set of bundles that exist across all admitted patient services. The next step is to classify all of those bundles. Obviously, the most trivial classification of all is to just lump them all into one group and say, here is the class of all general use item bundles. And you could define a bundle benefit for that broad collection, just a single benefit value and on average benefit. But what we do is we find more granular ways of dividing these bundles up into groups that create more homogeneity within each group. So that's the next stage. Stage 3 is the classification of the GUI bundles. So we've defined 3 classifications for the GUI bundles. The first basic classification is variant A, product only classification, where a single bundle variant is defined for each of the 24 product classes. So there are 24 bundle variants of this type, or end classes. This is a classification that takes all of those bundles we defined a minute ago and divides them into 24 classes based upon the product class to which they're associated. So in that example, there were 3 different bundles, and because there were 3 different product classes that are associated with that episode of care, those 3 bundles would be assigned to 3 different bundle variants in this classification. So the second type of classification that we define across the bundles is the facility type classification, which effectively takes each one of the 24 end classes defined in variant A and splits it based upon the facility type of that the episode of care occurred in, whether it's a private overnight facility, private day facility, or a public hospital facility. And so there are 72 end classes of that variant type, being the 24 end classes, each one split into 3, so 24 times 3. And then finally, we've got the major diagnostic category MDC grouping variant. So in this variant uses the actual major diagnostic category of the episode of care to define an end class for each bundle. And major diagnostic categories, or MDCs, form part of the Australian Refined Diagnosis Related Groups classification, or ARDRG classification. So as many of you are aware, the ARDRG classification is a classification of admitted episodes of care, and that classification system requires clinical data items, including clinical information present associated with an episode of care, including diagnoses and principal diagnoses and additional diagnoses, and also interventions. And the diagnoses are encoded using the ICD-10-AM classification, and the interventions are encoded using the ACHI classification. And so that's that clinical information is required in order to group an episode to a DRG. And the ARDRG classification is hierarchical. The DRGs are the most granular level. Adjacent DRGs are a level above an aggregation of DRGs, and then the MDCs are a level above that, being broad categories, about 25 categories across all episodes of care that each episode of care may be assigned to. And so using this classification associated with the episodes of care in which the general use items are used, we've got this grouping of episodes into up to 5 variants. And so each of the 24 bundle variants in variant A are split into up to 5 sub variants based upon the MDC. So that provides 3 different types of classifications that may be used to partition all of the general use item bundles. So the next stage and final stage is to define GUI bundle benefits against each end class. So each bundle variant is assigned a bundle benefit equal to the average prosthesis list benefits paid per episode for bundles of that variant. And it's not really benefits paid because the benefits weren't paid in this sense. They are the as I said at the start, they're the actual, the utilization of general use items with the March 2023 expected prosthesis list benefits associated with them. So they're what benefits would be paid if the activity had have occurred under the March 2023 prosthesis list schedule. So, and as I said, the actual benefit, the benefit defined against each bundle variant is defined equal to the average benefits paid per episode. And that obviously the average benefits paid per episode is determined by the mix of general use items across the bundles of that bundle variant, as well as their utilization rate, their rate of use. So if you've got, each product class has got a range of billing codes that sit under it, and hence there is a range of items that are used across the sector under that product class. And so there's an average mix of items used and an average benefit level for all of those items used, and that defines the average mix. And then you've got the average rate of use. So some episodes of care might only use one item, other episodes of care may use up to 10 items. And so the average rate of use is the other sort of input that both come together to define the bundle benefit or the average benefit per episode. And that's really described here in this formula. That's, the bundle benefit is equal to the average benefits per episode. And the average benefits per episode can be decomposed as the average benefits per item multiplied by the average items per episode. And that's how you can decompose the bundle benefit and understand what drives that value. Sometimes you can see that it's been driven by the profile of items used, so the benefits per item. Other times it's about the actual utilization of those items within an episode of care. And so you can there's a dynamic there that you can unpack and to help understand how the bundles are defined and how your data might compare to the national profile. So, someone's dropped something. So here's just an example of bundle variant A, the product only bundle variants. There's 24 bundles here you've got listed. Each one of these bundles has got a bundle benefit. And then on the right hand side, you can see that those bundle benefits are defined as, to be equal to average benefits per episode. And those average benefits per episode can be decomposed by benefits per item and items per episode. So that top row of balloon-based infusion pumps at $132.86 bundle benefit, that can be decomposed as an average benefit per item. So of all of the use of balloon-based infusion pumps, for example, across the sector, the average benefit paid per item used is $110. And that there's a range of scheduled benefits across this balloon-based infusion pump product class. And then you've got an average number of items used per episode of 1.208. So out of every 1,000 episodes, you would expect on average 1,208 of these balloon-based infusion pumps to be used. And so they combine to give the bundle benefit 132. And so then finally, we've just got another example of the matrix product class. So this particular matrix product class identifies a subset of bundles, and that's the matrix. And so this is a single class of the matrix bundle, matrix product only bundle. It has an average of $698.62, and that can be decomposed as $547.02 multiplied by a utilization rate of 1.277. And I'll just point out here that looking down here at the MDC grouping, the variant C type, you can see that these bundles are split into 4 different subclasses based upon the MDC grouping, and the highest class being $833 and the lowest being almost $400 less per bundle at $453. And you can see the actual breakdown of bundle benefits per item and items per episode. And in particular, you can see this is an example where the top class, the highest benefit class, has got an average benefit per item. So they're using a sort of the profile of products used in this highest class is not the highest cost product. It's $488 benefit rather than these ones lower that are higher. It's the actual utilization rate per episode that is increasing. So onto just finally the GUI bundle code. So that's it in a nutshell, how bundles are defined. We start with the identification of general use items. We classify the products, then we identify the bundles, classify the bundles, and then price the bundles. And then finally, on a more technical note, the purpose of this is to provide a basis on which an alternative payment mechanism may be created to replace the prostheses list payment mechanism that exists for these items and private services using these items. And so in particular, the prostheses list payment mechanism is encoded within the HCP data, like charges are raised against prostheses list billing codes and recorded in HCP charge data, and these prostheses list billing codes are 5-character codes, and we've used 5-character codes to define to encode general use item bundles. And so there's a hierarchy and a systematic a scheme to the actual encoding of the bundles. The first 2 characters of the product branch, the 3 characters of the product class, first 3 characters of product class, the 4th character is the bundle variant, and then together they create the bundle variant code. So that's carefully sort of defined, so to potentially be flexible and be amenable to be adapted over time for further use. These product classes may be expanded to create B lines or C lines or D lines. So you can expand this area of the encoding, and you can also expand the C variant type to create different variants, D, E, F, G, and so forth. And so there's an ability to potentially expand the classification over time. So that's the end of the overview of the bundles. Now I'm going to jump into a demonstration of the general use item bundling tool that we've developed. I'll skip out of that screen and skip into the bundling tool screen. So we intend to release this tool sometime in early Feb. We're just doing some final QA checks on it and all of that sort of thing, making sure there's no bugs. I'm not going to be able to do it justice today because there's a lot of functionality here in the tool. What I'm going to do is give a basic rundown of what you can do with it. So obviously there's an introduction page that gives a description of its functionalities and how to use it. There are data specifications associated with it that you can look into. Here we've got the main page of the tool, which is where you put the billing code data. The point of this tool is to take existing billing code level data, prostheses list billing code level charge data, import it in here, and then convert it to bundle data, and then look at how, so it outputs the bundle data, so you can effectively then take the output data set and use it as sort of bundle charge data. So you start with billing code level charge data, you end with bundle level charge data, and then secondly, it allows you to look at that data that you've input and benchmark it against the national profile of utilization of those particular general use items, those classes of items. So the first step is to actually input some data. I'm going to just take a sample of mock data here. You can see here that we've got just a record ID. It's prosthesis, it's device level information. So there's lots of, you can see here, there's multiple records here associated with a single episode of care. So it's a many-to-one relationship from this data set to an episode level data set. And there's other information that you can input, like the facility ID, the fund ID, facility type, the major diagnostic category, and the billing code, and also an item count associated with the billing code. So that's the form of the data that we're going to input. I'll just copy that across. Let's have a look. Here we go. Here's the data there. So once I've input the data in that format, the first step is to map billing code. So this first step is really, if you're inputting billing code level charge data, then chances are it's historical data, and it may not align with the August 2022 prostheses list. And so the first stage effectively maps the data forward wherever possible in cases where billing codes may have become superseded, discontinued, but have a viable transferred code that they map to. And so the first step is to map billing codes wherever appropriate. And over here on the left-hand side, you can toggle this mapping sequence. So you can see like where actually there's been a mapping that's occurred. So in this case, we input this billing code ER016, and it's mapped it to HW725. And here we've got a description of what the mapping was. And you can see there's like duplicated or transferred, and these sort of things happen as well as with the discontinuation of those original codes. So that's the first stage. I'll just toggle that back off. Next stage is to identify general use items. This data could contain general use items as well as other prostheses list items that are not identified as general use. So the next stage is to identify the general use items. And so that's done. And so here we've got some extra flags that say true or false whether the item is general use. If it is identified as a general use item, it provides the expected March 23 prostheses list schedule benefit, multiplied by the number of items. So this is the sort of the benefit level at this level for general use items. The next stage is to select the bundles. So there's as we saw before, a range of different classifications, and basically for each product class we've got here, we can either select whether we want the bundle to apply or not. And then for those bundles that product classes that we do want to bundle, identify for bundling, we can define whether we want one particular bundle or another, a facility type, classification, product only, or the MDC grouping. So once we've got that selected, we go back to the input data. And then the final step is to assign bundles. So we assign the bundles. Usually doesn't take this long. There we go. So we've defined the bundles. On this page, it's sort of like this isn't the bundles. This is still billing code level data. So it hasn't been rolled up on this view, but it is still sort of an assignment of a billing code to what bundle it's associated with. So then we can look. There's two different options here. The first thing we can do is go to the benefits by episode and bundle, which is the bundle outputs. So we go to that tab, and each record here is a bundle. So you can see like for this record here, it's got the same episode ID, E23. There are two bundles that are present within that episode, and that's what codes they are, and that's their bundle benefit there. And here we've got recorded what their original benefit would be had they been priced at an item level, paid at an item level. So you've got the two comparisons there at a bundle level. And then we've got these other records here, which is effectively what all of the non-GUIs have been rolled up into. So there's a whole bunch of data there that may not be general use item data, and they effectively get rolled up into those no bundle items. And you can filter them out. So you could filter out no bundles, throw those records away, and what you're left with is your bundle charge data. So then we're going to go back to the return to the input data. The final thing we're going to do is to look at benchmarking comparison. So select that, and I might toggle them off to start with. Here we've got a list of all of the bundles defined across the input data related to what we've specified as the bundles, like whether it's a C variant bundle or a B variant bundle. So all of these bundles are based upon our selection of bundle type that we made. Here we've got a count of the actual bundles that we've got present within the data, and for each one of these group of bundles, we've got the actual what the input data has got as on an item level payment. So if these billing codes were paid at an item level, for example, looking at this guy here, it'll be $142.01 per episode or per bundle, whereas the national profile and the bundle benefit is $140. So you can see like there's $2 more per episode that they would be receiving under the prostheses level prostheses list payment mechanism compared to a bundle payment mechanism. And then you can see, well, okay, that's higher. Why is it higher? Is it because of the average benefits per item? No, it's not. Actually, they're using a lower than average benefit per item. It's because they're using 1.13, they're using a higher than average number of items per episode. That's why they're finding themselves above the national average benefits per episode. And then these toggles up here that I switched off to start with effectively look at the percentiles for each one of these different breakdowns. And so this is a graphical illustration of where the input data sits relative to the percentiles of the distribution on the national profile. So that and the tables provide the actual percentiles as values. So there you go. That's the actual functionality of the tool. The tool has input tables that it uses that are listed across here. So it's a sort of a self-contained tool. And that's where I'm going to end that demonstration. And I think it is time for the Q&A part of the webinar. So I'm joined now by the others. Over to you, James.
All right. Thanks, Trent. So we'll now start our live Q&A. I can see there's already a lot of questions coming in. We've got about 25 minutes for questions, but please keep posting questions via the Q&A widget in your browser, and please continue to upvote those questions that are of interest to you. So let's start with our first question. So it's a question about new technology. So how is new technology going to be added to the bundle variants if it does not fit into pre-existing bundles? And can new bundle variants be created? Probably take that to you, Trent.
Yeah, sure. I mean, I think there's various ways in which the bundles may and will evolve over time. I think that one of the ways they may evolve is, as I mentioned earlier, is that, you know, the original scope is this list of items that are registered under, that are listed, that can be charged under prostheses, under billing codes listed on the prostheses list. But now that these items will no longer be listed on the prostheses list, there's potentially a broader set of items that may be used, that may fall under a payment mechanism like this. But similarly, the product classes may be extended to create other product classes, or maybe the product classes may be refined over time to be more restricted in the types of products that are allowable under a certain product class. And those particular arrangements may be individual between agreements between two parties. They may not be universal and nationally applied. They may just be worked out as arrangements between contracting parties. And, you know, any change, such as any one of those changes, is going to potentially have two types of effects. It's either going to change the profile of items used, and so it's going to hence change the average benefits per item that you're willing to charge, agree to charge at and agree to pay benefits at. So an average benefit per item, and you're going to agree to a profile of utilization on per episode, so an average utilization per episode. And if there's an existing bundle already there, and the product class evolves over time, then the conversation is going to be about how those two things change, whether the average benefit should go up per item and the average number of items per episode go down, or what happens. And so you tweak those two items and you'll arrive at a revised benefit level. So I figure that's generally how it might play out. It will obviously be a lot more complicated than that, because these things always are. But generally speaking, I figure that's the sort of framework in which you can negotiate departures from this nationally defined set of bundles.
Thanks, Trent. We've got another question that's come up about the bundle variants. So how do you see these bundle variants being used? Will hospitals and health funds negotiate which ones they'll use, or will it be up to the department to select?
So I can probably take that one. So originally when IHACPA was asked to provide this advice, it was advice to support the sector, as we said, as our overview. And it's one of the reasons why we have tried to be as flexible as possible with the advice in terms of the variance of the bundles and also the bundling tool to enable hospitals to have the information at their fingertips in order to negotiate. And the implementation of the prosthesis list and changes around that is the domain of the department. Many of you will have been involved in the stakeholder engagement that the department has undertaken with this work as well. So in terms of, from our point of view, we've provided the advice and the tool, and we will provide supplementary advice in April if required, but ultimately the implementation is for the department. But the department has undertaken to do work and to consult on this, and essentially they've committed to a new funding arrangement for the general use items that will be removed from 1 July 2023, and they're intending to mandate that through changes to the Private Health Insurance Act. And the department, I believe, in the next couple of weeks is going to release a consultation paper on that to consult with the sector on how that approach might work and the practicalities of what mandating bundles might look like. So all of that information is there for the sector, but the department is sort of moving forward on the implementation and consulting on mandating those bundles.
Thanks, Joe. I can see there's some questions coming up about the tool. We might save those for the last 10 minutes, and we can bring up the tool again, where Trent can probably go through some of the answers to those. We've just got another answer from Jane. So a question from Jane. So what arrangements are there for those hospitals without PHI contracts and reliant on second-tier default benefits?
Well, maybe there's a range of different arrangements that are already existing.
For you, Trent, or Keys?
No. You go, Keith. What are you?
No, go, Trent. I'm happy for you to.
Look,
anything else?
But there's obviously, this change occurs in the broader context of a whole range of other existing agreements that are in place between insurers and hospitals, and some of those agreements are completely distinct from the prostheses list payment mechanism, and other components of the agreements may somehow be aligned in some way that potentially distorts the way in which billing code level billing prostheses list items are charged and charges the rates for them. So there's all different ways in which there's a much broader context in which this reform is occurring. What we've tried to do is to just basically be as carefully defined as possible to sort of swap out one mechanism for another. But that swapping theoretically is done in a way as sort of equilibrium with all the other existing arrangements. And so that's the starting point. I feel like, that once you have a viable alternative mechanism potentially that may be adopted, then there can be conversations about how you might be able to, how it might be able to integrated with these other existing arrangements. Like, I guess I don't have any answer to the question, basically, is the short answer, but it's a conversation. It's really just, here's a replacement mechanism. What's the dynamic of this new mechanism in the broader context of the rest of the prostheses list payment mechanism and any other arrangements that might also be existing and in place.
All right. Thanks, Trent. We've got a couple of questions from Edward. I'll start off with the first one. So and they're about modelling. So given IHACPA modelling focused on neutrality at the national level, some hospitals will be worse off. Do we know what percentage of hospitals are worse off, and what does this look like at the DRG level, and what does this look like at the private insurer level?
Yeah, so you can, we didn't mention this earlier, but I mean, we sort of took it as given, but all of the detail on much more detail on the actual bundles and their definition, as well as the methodology and data sources and all of that. Or maybe you mentioned at the start, Joe, you did. All of this further detail is provided in the actual, in our advice. But, you know, and you can cut this a million different ways. And the way in which these sort of bundles work, any type of bundling works. Like there's bundling in the public sector for activity-based funding, you know, services are bundled up to an admitted episode of care, an emergency department episode of care, and so forth, and classified into their end classes. It happens across all different funding arrangements and service types. And in every case, there's a level of aggregation. And once you've got that level of aggregation, if you're aggregating from a more granularly defined mechanism, payment mechanism, then you're bound to have these swings and roundabouts of how things even out to an average. And the bigger the volume is, the more aligned you will be to the, you know, to the overall average. And the smaller you are, the more inclined you might be to bigger differences compared to the national average. I don't have off the top of my head what the proportion of, you know, hospitals may just have a single general used item that they've charged. They may have, you know, 50,000. They may have any range, and so depending upon that number of items that are charged, there'll be a propensity or otherwise to fluctuate from the national average. And so I get maybe the way to answer this then is, like, you know, you can break it down by a DRG or by MDC or by hospital or by fund and so forth. The part of our advice was an Appendix D, which provided these percentile statistics, which looked at different sample sizes. So as I said, like the smaller the sample size is, the more likely that there may be greater fluctuation compared to the national average. And so this Appendix D basically looks at percentiles of variation and shows that, you know, it demonstrates that the smaller the sample size, the wider the variation. And so that appendix can be used to effectively benchmark, and what is used in that tool that we demonstrated to look at, generally speaking, what that distribution is. But we don't have the statistics at hand on a given breakdown, you know, say by MDC or by facility or fund.
Great, thanks, Trent. So the second question that Edward has is around modelling. So at the heart of the AHACPA modelling is cross-subsidisation. So whereby insurers or hospitals with higher GUIs use receive less funding, while insurers and hospitals with lower GUI use receive more funding. So this can potentially create a moral hazard of selecting and excluding patients based on profitability. So was this evaluated, or how was this evaluated throughout the modelling, and was it accepted?
Well, I mean, like as we said, it is inevitable. There's nothing you can do. If you're going to set a single benefit at an aggregate level, there'll always be a variation around that aggregation. You'll never avoid it unless you just continue to pay at an item level, right? So that's the alternative, is to have the original 500 or 492 different benefit levels and pay at a device level. So that's the alternative mechanism that's not bundled. You know, like, and the purpose of these classifications that we've got, the variant A, B, and C classifications, is to effectively define, is to assist with making the N classes more homogeneous. As I said, just in the presentation, you can just define all the bundles, identify them, and just take all of them and say, we're just going to give a single price for each one, a single benefit for each one. And that's a viable approach, right? On average, overall, nationally, there will be net zero difference compared to the existing payment mechanism. Obviously, there'll be bigger variation at you know, a local level, hospital or fund level. And so what we do is we look at MDC grouping, or we look at facility type, because we understand that there is distinct variation that's clinically, founded. And that's the basis on which we make these classifications. So an MDC grouping uses clinical characteristics to group into broad groupings based upon utilisation and average benefits, or that's facility type, because it's understood that private overnight facilities have fundamentally different services and usage profiles compared to day facilities. So that's the basis on which we do that, and we do that using a rationale. And if you can invent a new classification and have a new rationale for that, and maybe that needs to occur over time. But these are the three different classifications that we've had as a starting point for these bundles.
Just to reinforce a couple of things Trent said, I guess about the inevitability of this is the way it is with bundling arrangements. Our understanding is that this option of bundling arrangements was a suggestion of the private sector in the history of the whole prosthesis list reforms and the discussion on the general use items, that this option was put forward by the private sector as one to investigate and one that they wanted advice on, hence why we were asked to develop this advice. So I think just recognising it is, it is something the sector put forward as an option once those items were removed, and that's what we've done. We've come up with bundles and options for the sector and the tools in which they can actually analyse their data and potentially negotiate use specific to what their hospitals and patients needs.
All right, thanks, Joe. Thanks, Trent. We've got another question about the bundling arrangements overall. So Simon's asking, this appears to be incredibly complex by comparison to the status quo. So what are the benefits this system has to the healthcare industry which justify this level of complexity? Maybe Kees, I think this is right up your alley.
Thank you. So I think, it builds on what Joe and Trent were saying before, is that obviously, we were asked to provide input into a process that was on the way, in the sense that the GUI items were being taken off the prosthesis list, and on the basis of that, how do you then switch to an alternative? And so that's the starting point. And I think, as Trent mentioned, something like 500 billing codes or items in the GUI group has now come down to a maximum of 54. So in many ways, I don't think it is more complicated. But of course, things are, change is always hard. So that is just one of the things that I think the sector can hopefully deal with in a quite a transactions sort of and in a systematic way.
I also think, just on that point of the transition is hard, the change is hard. But if you imagine the departure, so we've departed from this prosthesis, this item level billing arrangement, then you've got an episode level charging arrangement. You've got less different levels of charge rates, and potentially you can combine them over time. You can broaden them, and you can just move over time towards an episodic payment that has got all of these sub bundles components, and you can change the components, and then you've just got a single payment for an episode. Now, sure, you have to go through a complex sort of methodological process, and the change is hard, but the end target state is much more simple. That's at least one perspective on it.
Thanks, Trent. Thanks, Kees. We've got just another question about new technology. So Michelle's asking, who will be the responsible department to allocate the new technology to a respective bundle or MDC when an MDC doesn't exist?
So I can answer that one. So the major diagnostic category is based on the principal diagnosis of an episode of care. So it's not necessarily reliant on any interventions or the procedures or the particular technology. So any episode which is coded will have to have a principal diagnosis, and that principal diagnosis will determine what the major diagnostic category is for that record. And that is something that IHACPA does, manages the AR-DRG classification. Every 3 years we produce new versions, and so whenever there is a new code added to the diagnosis classification of ICD-10-AM, we are required to allocate it to an MDC in the associated AR-DRG classification update that happens on the same cycle. So it's not going to be an issue in terms of episodes being unable to be allocated to an MDC. If it's coded, it will be able to be assigned to an MDC.
Thanks, Joe. Darren's asking, when will a decision be made regarding the type of bundling variant that will be followed? So, for example, product, facility type, or MDC. I'm not sure if Joe, is this right up your alley?
Yeah. So that's what the department is going to consult on in the next couple of weeks. As we understand that they'll be releasing a consultation paper and consulting throughout February and early March on that in terms of options for which of those variants could be used in which circumstances. So that is all still to be determined.
Thanks, Joe. We've got a suggestion from Michelle. So could IHACPA provide the national mapping capturing the ICD-10 ACHI in an Excel format for attendees after the session? Is that something that we're able to do?
I'm just trying to think of what we've already got available electronically.
I feel like, Joe, there's nothing about ACHI that goes to MDC aside from the pre-MDC situation. Is there something in the DRG development publications that talks about those default, the adjacent DRG that codes get assigned to?
Yeah, it's certainly in the definitions manual. I think we'll take that one on notice. It's certainly in the AR-DRG definition manuals, the mapping between diagnosis codes and MDCs, and a lot of those appendices are available electronically. I'm just not sure off the top of my head whether that one is, but that's one that we can, we can follow up in concluding the questions that we might not get to in the session. So we will see what we can do with that one.
Thanks, Joe. Thanks, Trent. So Brad's asking, who decides what bundle variant to use? So is it a decision between insurers and hospitals at a site level?
So that's also an implementation question, I guess. So originally with the advice, which was advice to the sector, that would be open to negotiation between the private hospital and the insurer. But obviously the approach to consider mandating those bundles might impact that slightly. And again, going back to it, that's what the department will be consulting on in terms of practicalities around mandating those bundles and which ones are used in which circumstances.
I might just add as well, the bundles are defined so that a different variant branch may be applied depending upon the different product class. So you might apply just the straight product bundle for one product class, and then you may split another product class by public-private overnight day facility, and you might split another product class by the MDC-based grouping. So you can be flexible in the application by product class.
Perfect. Thanks, Keith. Sorry, thanks, Trent. Thanks, Joe. We've got another question that's been quite highly voted, and I know that we've got about 5 minutes left. But Julian's asked that can we provide a working example of a mapping of a rebate code to the benefit amount for each variant? So just to ensure that they're using the right logic to determine the bundle benefit. I think, Trent, you did do an example on the spreadsheet before, but perhaps maybe we can go through another example.
Yeah, I mean, we can swap to that, but basically the tool effectively provides that functionality. You can put in whatever data you want into the tool. You can select the bundle variant type that you want to apply, and it'll output the comparison of benefits. And so you can select one bundle variant type, and then another, and then another, and you know, you can sort of combine them together and compare the outcomes based upon different selection of the bundle variant branches. So I'm happy to drop back into the tool, but I'm also happy to continue. Like, that will be possible once the tool gets released.
I think, yeah, look, I'm happy to continue with questions. We've got a lot, and I think we had a pretty good example beforehand, and that was a nice explanation as well. Sharon's asking, how will these bundles be maintained if these general miscellaneous items are coming off the PL effective 1st of July 23? That's another implementation question.
Yeah, but I mean, we've been asked to provide this advice specifically at a point in time relating to a specific implementation, within prostheses list reform. We have not been asked to provide any regular updates or anything like that, at this point. But I feel like there's various different ways in which this might evolve over time. Individual arrangements may evolve and be customized based upon this starting point. The department might choose some particular reform activity in future that might have implications with regard to updating of these bundles. Who knows what the actual next stages are?
Yeah, and I think that's a really important point. It's part of the. Sorry, James.
Probably our last question, just given the time.
Could you hear me, James?
I could hear you.
Okay, sorry, Joe. I was just going to say, yeah, and that is, of course, also part of the implementation issues, and depending on where that goes, it will have further repercussions on the data that needs to be collected, so that these bundles can get updated over time with the sort of data processes that we've just undergone with the current items on the GUI.
Thank you. All right, we've got our last question now, just for time. So Darren's asking, what would be the mechanism for expanding the bundles in a nationally consistent way to ensure equitable access to new technologies? So will this be clinical or administrative?
Well, I think I started answering that question, so I might as well continue. But I think so. Again, this is part of the processes that I think the department will now take forward as far as the implementation is concerned. But obviously there is certain ways that you can think about doing that, and in some ways you can think about it as far as a prospective way of updating these things, updating the bundles when there is a new piece of technology that you'd like to integrate. And obviously there's an entire assessment process that would need to be undertaken with that. The other way is that you could do this retrospectively if this is coming into the system and can be captured in the data, that these then get updated in a retrospective way, or something in between. And so these are sort of the considerations that need to be considered in the implementation phases.
All right, thanks, Keith. So that's all we have time for today. So thank you all, and thank you to all our panelists. And I'll throw it back to you, Joe, to tie things up.
Thanks, James, for moderating for us, and thanks to all those participants today and all of your questions. We'll see what we can do about finalising the ones that we didn't get to. We'll just have to have some internal discussions about that. But I hope we have been able to provide you with an understanding of our advice, and I'm sure you're all looking forward to getting your hands on the bundling tool, which, as I said earlier, we're intending to release in early February, and we will send out a stakeholder notification when that is ready. And thanks again for your participation, and I hope you enjoy the rest of your day. Bye for now.